Okay, good afternoon, everyone. So today I'll be presenting on this acid-base balance, but just the general principle of acid-base balance. Can you hear Priscilla? Because the topic will be quite big, so eventually you guys still have to go back and read on it. So we'll be talking about acidosis and alkalosis. And alkalosis normally is when the pH is kicking up, and while the acidosis is when the pH is sliding down. So my outlines today is basics of acid-base balance, metabolic acidosis and metabolic alkalosis, where metabolic acidosis is the most frequent blood gas that we actually encounter. Mixed acid-base disorder.
Actually, when did it come out also? I didn't know. I didn't know.
We will not be covering respiratory acidosis or alkalosis in this topic. Okay, so we start with the case first. There's a 45-year-old gentleman presented with fever, cough, and shortness of breath for 3 days, hypotensive and started on inotropic support. The renal profile shows sodium of 140, potassium of 5, chloride of 105, ABG shows pH of 7.32, PCO2 is 30, and bicarb of 15. So based on this case, what is the acid-base disorder? You guys can just try to analyze and then keep it in the back of your mind first. Okay, so let's start it very slow first. So disorder of acid-base balance can have actually major clinical and diagnostic implications because in extreme pH condition, we can actually alter the tertiary structure of any proteins in our body, and it can even affect our enzymes activity and also the ion transport system. So in basic thing you need to know is we have 3 types of regulation of our acid-base balance, mainly our respiratory system, the renal system, and the buffer system, which consists of bicarb and non-bicarbonate. So if you see here, let's say this is your body, the compensation or wherever the regulation of acid-base balance based on the respiratory system is your CO2, and the kidney will be the excretion of H hydrogen ions, as well as the reclamation of bicarbs. Okay, so the normal parameters that we all know, pH is 7.35 to 7.45, PCO2 35 to 45, and bicarb of 22 to 26. So simple acid-base disorder, in the case of metabolic acidosis, mostly are due to excess generation of metabolic acids, excessive exogenous acid intake, reduced kidney excretion of acid, excessive exogenous loss of bicarb, while metabolic alkalosis is due to exogenous intake of bicarb salts, endogenous generation of bicarb, and the pathology normally include reduced or impaired renal bicarb excretion. Later I will tell you a few causes of it. And in terms of respiratory acidosis, normally if we get in a case of respiratory acidosis, we will usually have our compensatory mechanism, which will come into action. Acute phase will be our buffer system, and the chronic phase will be the renal. Same goes with respiratory alkalosis. Okay, so step by step, normally for you to interpret a blood gas, of course, you must see the history and the physical examination of the patient. And then you do an ABG analysis, which focus on your pH, PCO2, and bicarb. And then you have to calculate your anion gap. And based on these 3, you can actually predict patient's compensatory response to our simple acid-base disorder. And then when you go another more higher level, we can actually analyze the degree of change in the anion gap and the degree of change in the bicarb to see whether or not it's actually reciprocal change. That means whether or not the compensatory mechanism is sufficient or patient actually have mixed acid-base disorder. So anion gap, if you all know, actually there are 2 formulas that can be used with or without potassium. Of course, with potassium is actually sodium plus potassium minus chloride plus bicarb. And without potassium, you actually remove the potassium from the formula. And you can actually use both, but mostly we can use without potassium because the potassium concentration is so low that there's little effect to the anion gap. And our normal anion gap is actually 10 plus minus 2. Okay, so if you see this, our normal ionic anatomy of a plasma, the cation charges, which is your positive charge, must always be equivalent to your anion charge in your body. Your sodium, potassium, calcium, magnesium must be equilibrium with your chloride, with your bicarb, as well as all the other anion charge here. So when we actually calculate, you get the anion gap. So how about those patients in hypoalbuminemia? in terms of hypoalbuminemia by right, we have to give a corrected N-ion gap formula, which is your N-ion gap plus 2.5 with the 4 minus of your serum albumin. Okay, so let's talk about metabolic acidosis. So in terms of metabolic acidosis, there are all those non-volatile acids accumulation in the body. And it's actually to maintain our extracellular pH, must be a daily production of acid, must be excreted from the body through the kidney system. So in terms of kidney system, there is an excretion of acid as the distal tubule, reclamation of filtered bicarb at the proximal tubule, your PCT, and also ammonia genesis. So this is your, for example, if you imagine this is your physiological usual in your body. So whenever there is an acid addition, which is your metabolism of your protein, we have to regulate this kind of acid where there will be acid excretion or there will be a base loss from your stool or your urine, which is your bicarb. So any interference with all this flow chart over here will actually interfere with your blood gas in your body. Okay, so this is a diagram of your distal convoluted tube. So if you see that we have excretion of acid, which is your H+, through the H+ ATPase pump, through the tubular lumen. And when you excrete your hydrogen ion, normally there will be absorption of bicarb over here. And then this is your carbonate anhydrase 2 enzyme. And then if there's an absorption of your bicarb from your proximal convoluted tube, as you can see here, the bicarb is being absorbed back through the pump, as well as there's also excretion of hydrogen ion into the urine. As you can see this diagram, whenever there is a change of a physiological change, for example, in terms of increased acid production like lactate acidosis, ketoacidosis, or any drugs or toxin, then you will increase in your acid addition, which affects your blood gas in your body. And then for you to actually regulate it, that's where your buffer system will come in. Or if you have increase in base loss in your stool, such as diarrhea, such as in a case of increase in bicarb in proximal RTA, or there is decrease in ammonia excretion over here. Okay. So our metabolic acidosis, we can actually divide it into high anion gap metabolic acidosis or normal anion gap metabolic acidosis. And this is the mnemonic that you guys must remember, causes of high anion gap metabolic acidosis. You can use this cat mud pulse. So this one can Google also, you all can find, but most of the time we always encounter this DKA, PCM. Must remember isoniazid also can cause high anion gap metabolic acidosis or even ethylene glycol or this aspirin toxicity. And the causes of normal anion gap metabolic acidosis is over here. That's why I say there are a lot of causes, but you guys have to read further in the detail. If not, we won't be able to cover everything in half an hour to 1 hour. Okay, so simplified approach to your metabolic acidosis. Number one, determine is it metabolic acidosis or not. Number two, you calculate your anion gap, whether is it a high anion gap metabolic acidosis, which is your HAGMA, HAGMA or NAGMA, normal anion gap metabolic acidosis. Once you determine, then you will see respiratory compensation, and then you can use this Winter's formula to tell you whether or not there is an appropriateness of respiratory compensation. And if it's not, probably there is a mixed disorder where you can calculate the delta ratio. Okay, so for example, this is the Winter's formula. In the case of metabolic acidosis, the pH will be low, the bicarb will be low, and we expect the PCO2 to be low due to respiratory compensation due to CO2 washout. So if you calculate the PCO2 by right, should be 1.5 times bicarb plus 8, and then that should be your expected PCO2 level for the patient. We will actually show you I will actually show you a calculation at the end of the slides. So this is what we call as a Winter's formula. So delta gap, this one probably is a bit more difficult. So just keep it at the back of the mind, because whenever there's an anion gap metabolic acidosis, either it is a single acid base or there is a mixed acid base disorder. So if your delta anion gap is actually more than your bicarb, there is a presence of additional acid base disorder, such as your HAGMA plus metabolic alkalosis or HAGMA plus chronic respiratory acidosis. But if your anion gap is less than your bicarb, then it's always HAGMA plus hyperchloremic metabolic acidosis or HAGMA plus chronic respiratory alkalosis. So this is a summary of the calculation that you can do for your delta ratio. Probably this might not be that relevant, or maybe it's more relevant in intensive care setting. Okay, so let's try a bit more higher information. Evaluation of urinary acidification, because our kidney is quite responsible for both the reclamation of our filter bicarb as well as our excretion of hydrogen. So we should assess whether the kidney is actually appropriate, able to reabsorb your bicarb as well as secrete your hydrogen and excrete all the ammonia. So we can actually check by urine pH, urine ammonia, urine anion gap, urine osmolar gap, urine osmolality, or even urine PCO2 with bicarb loading. This is a diagram that shows base normal ammonia excretion if there's a decrease in the ammonia excretion as well. Sorry. So in the case of urine anion gap, if in the case of metabolic acidosis without a serum anion gap, if you can calculate your urine anion gap, if positive, then it could be a RTA. If it's negative, it could be due to diarrhea causing the metabolic acidosis. Okay, so this is a simple diagram of a hyperchloremic metabolic acidosis. So if you can see that in the case of hyperchloremic metabolic acidosis, there's a defect in your bicarb reclamation. So it's known as a proximal RTA. Defect in the hydrogen circulation is a distal RTA. If there's an extra renal loss, due to diarrhea. And RTA will be divided into your urine pH. You all can take a picture. I'm not going to go into detail for this one. Okay, so in terms of metabolic alkalosis, bicarb ions are actually freely filtered across the glomerulus and must be actually completely recaptured by the tubal urines. So exit excretion also must actually occur to regenerate any bicarb consumed in buffering of endogenous produced acid. And our hydrogen ions are secreted into the renal tubules, combined with our filtered bicarb to produce water as well as CO2. And the secreted hydrogen generate new bicarb inside the cell that is then added to our peritubular blood. And in proximal tubule as well as the ascending lobe of Handy, these are the ATPase pump that we have been using it, sodium hydrogen exchanger as well as the H+ ATPase pump. Okay, so causes of metabolic alkalosis normally due to increased alkali intake with renal failure, extra renal chloride losses with secondary renal potassium loss, diuretics, mineral corticoid-induced hyperaldosteronism. And this one you can also find through your textbook or even on Google. There are a lot of causes of metabolic alkalosis. And this one is also based on your urinary chloride level. Okay, so this is a simple table that is more relevant. So for example, if you see you have a pH of less than 7.36 or 7.35, next you see your bicarb and your PCO2. So if you have a low bicarb, high PCO2, then you know that this is a mixed metabolic acidosis and respiratory acidosis. But you have a low bicarb, low PCO2, then you know this is a predominant metabolic acidosis. That's where you apply your compensation rule, which is the Winter's formula. So if your Winter's formula shows that your PCO2 is actually higher than the one on your blood gas, then you know it's a mixed metabolic acidosis and respiratory acidosis. But if your PCO2 is just too low from your Winter's formula, you know that this is a mixed metabolic acidosis and respiratory alkalosis. But if your PCO2 is actually appropriate, then you know this is a simple metabolic acidosis. But if you have a high bicarb, low pH, and high PCO2, then you know this is a predominant respiratory acidosis. And then you can apply your compensation rule as well. And then this is your high bicarb, low PCO2. Probably this is a lab error, a bit unlikely to be. Okay. And then this is the summary of your alkalosis. If the pH is high, look through your bicarb and look through your PCO2. So if you see there's a high bicarb, low PCO2, you know this is a mixed metabolic alkalosis and respiratory alkalosis. But if there's a high bicarb, high PCO2 is a predominant metabolic alkalosis. Low bicarb, low PCO2, predominant respiratory alkalosis. Low bicarb, high PCO2, probably is a lab error as well. So what is mixed acid-base disturbance? Means there's occurrence of two or more simple acid-base disturbance simultaneously. It can be concurrent occurrence together or sequential from the first disturbance. And it always have a directional effect on the pH or opposing each other. So in the case of salicylate poisoning, you get a high anion gap metabolic acidosis with respiratory alkalosis. Or DKA with vomiting, you get the high anion gap metabolic acidosis with metabolic alkalosis. So back to the case just now, the 45-year-old gentleman presented with fever, cough, and shortness of breath for 3 days. Patient is hypotensive, started on inotropic support. Renal profile sodium is 140, potassium is 5 with a chloride of 105. And your pH is 7.32, your PCO2 is 30, and your bicarb is 15. Perhaps anyone can try to answer what is the acid-base disorder. Anyone is fine. If not, I can give the answer already. Okay, fine, never mind. So if you look at this, pH is low, bicarb is low, and your PCO2 is low. So you know that this is a metabolic acidosis with respiratory compensation, as patient having CO2 washout. So when you calculate the anion gap, sodium 140 minus your bicarb plus your chloride is 20. All right, and you apply your Winter's formula, which is your PCO2 is expected to be 30 plus minus 2. So you know that there is an appropriate compensation of the PCO2. So therefore, this is actually a high anion gap metabolic acidosis with appropriate compensation from your respiratory system. But what if your PCO2 becomes 40? Same goes with the formula. If you calculate the Winter's formula, you're expected to be 30, but your measured PCO2 is 40. So you know that this patient is having respiratory acidosis. Therefore, this patient actually have a mixed acid-base disorder where there is a mixed acid, a high anion gap metabolic acidosis with respiratory acidosis. All right. Very confusing, right? Actually, probably that's all from me, very fast 15 minutes presentation. So I think you guys have to read back on your blood gas first because it's actually very summarized, but everything is quite, it's actually very big topic. So I try to summarize as much as possible. So I think this slide should be more relevant to you all, as well as this slide also. The approach of acidemia and approach of alkalemia. Probably if you want a summary, these two will be relevant if you want it to be a very quick answer to your blood gas. Okay. So, yep. All right. Okay. I think that's all from me.